So today's session, titled Our Digital Health Programs Delivering Measurable ROI, is brought to us by Scene Health. Scene Health has been a longtime partner and supporter of both MHPA and our health plan members. I want to thank the entire Scene Health team for organizing today's session. With that, I'll go ahead and toss things over to Reza Alavi, our moderator for today, who is the Managing Director at Quintuple Lane, for introductions and today's content.
Hi, everyone. I'm Reza Alavi, internal medicine doctor by training. Spent the last 15 years in population health. I'm super excited to facilitate this conversation around digital health ROI, right? There's a lot of folks that are buyers and sellers of solutions that have been struggling with how do we really account for the value that people are bringing to the marketplace. So without further ado, I'm going to start introducing some of our panelists. I will turn it over to Rebecca.
Hi, good afternoon. Rebecca Geist, National Director of Business Development and Strategy, Kaiser Prominence Health.
Ifrad.
Hi there. Good morning or good afternoon. I'm Ifrad Islam, Vice President at Prominence Health, which is a health plan and ACO, managing over 150,000 Medicare, Medicare Advantage, and commercial members. My background is in data analytics and medical economics. Nice to be here.
Right. Mike.
Hi, good afternoon. I'm Mike Raypatch. I'm the Senior Vice President for Government Programs and the President and CEO of the CareFirst Community Health Plan for our Medicaid business at CareFirst Blue Cross Blue Shield.
And Sebastian.
Hi, everybody. Sebastian Sager. I'm the CEO and co-founder of Scene Health. We're a Johns Hopkins spin-out that's now about 11 years old. And Reza, thank you so much for moderating today. And Ifrad, Mike, and Rebecca, awesome to be on with you.
All right, so we'll start at the high level, thinking about what works and what doesn't work. So Mike, you guys do a lot of pilots with different digital solutions. Tell me, like, at a very high level, how do you evaluate digital health startups and solutions that you're using in the marketplace?
Sure. So first off, we're usually looking for something that gives us new information or a new perspective. And so we get a lot of these approaches that come and are trying to bring scale to various solutions. And, in many ways, we're a large insurance company. We have a lot of solutions already in the book. So it's a question of what's new, what's different, what's an angle about this we don't understand, and how would it impact our members? How would it impact our business? How do we then take the next step of that? And then we are aiming to try to see what we learn. ROI is always part of that conversation, but it isn't always the core driver, as the populations we're serving, especially in the government space, are very complex. And often we're trying to gain an understanding of something we don't know, or that is a different angle that we haven't considered, and try to figure out how that makes our operations and our capabilities better over periods of time. So we kind of look at it as a holistic question, not just what's the dollar value return of the effort, but also what's the rest of the package and the picture that comes along with it.
Rebecca, as you guys look to do population health at scale and you're looking to layer on solutions, everybody talks about value-based care, but what is it that we value? Like, what are the different domains that a company, before we get into how we measure it, but what are the different domains that they can drive value for an organization like yourselves?
It's a great question. So we are an integrated delivery system, integrated care, of course, but a value-based system. It's very fundamental and core to our mission and values. So one of the things I would say we value is partners who are equally value-based, have a value-based foundational aspect through contractual arrangements. So one of the things is that when we think about value, it's not only that pricing perspective through like a value-based contract with a vendor, it's equally the value to the organization, similar to what Mike said, but it's the value to the member. And that member experience to us as an organization is first and foremost very critical. Our members, we're a little bit different than other payers at times where we have all lines of business products. So that member experience, we want to make sure within every product, specifically government programs, is very strong. And, not only that PCP bonding, and within our system, but any vendor that we consider, we want to make sure it's such a high caliber experience, because we want to make sure that that vendor is a reflection of our mission and values as well. And that member wants to retain care and coverage with us long term. So it's not just that financial component. We value the right partner at the right time, specifically for the alignment of this specific issue we're trying to solve. The vendor space, of course, can be crowded. There's a lot of wonderful vendors out there, but making sure that from a value perspective, we are valuing the vendor within the right segment to impact a population is really critical, because we want to make sure it's a successful venture for not only the vendor, our members, and ourselves.
How do we know, Rebecca, like if I'm a vendor, how do I know what are your let's say I do drive value in a couple different diseases, couple different segments. How do I know what are your priorities, and like who should I be talking to, at a different organization?
Well, for us specifically, I think that we have to make sure there's a clear delineation and delegation of duties. So from that member's perspective, touching that member in too many manners, whether it be through care management or whether it be through just our primary care physicians, we want to make sure everyone's first and foremost on the same page. In order to eliminate member confusion, we want to make sure there's high adoption and engagement. So specifically, I think that there's a lot of perspective within our organization, because we want to make sure it's the right fit, that the workflows are appropriate, and that it makes sense. So from a who to talk to, we always want to make sure our market-specific chief medical officers at the table, our operational leads, folks like myself in business development, of course, by finance and the actuarial folks, as well as folks within our care delivery, our Prominence Health physicians, of course, because we want to make sure that, as being one of the highest quality health plans in the country, we want to make sure that quality is, protected within that member space. So there's a lot of different stakeholders that go into a vetting process for a vendor, specifically then drilling down to data optimization, understanding exactly what is impactable, what cohorts of members, and what's the needle to move on it. And also looking at, is this a chronic condition? Is this something that has been exacerbated through potentially a natural disaster? So we do know that, natural disasters are increasing. So you might have folks that have more episodic, right? That might have high utilization, but it's a point in period of time. So all those things are definitely something we factor. So to answer you, it's not a simple question to ask, because there's a lot of stakeholders, and I think that's the right approach, because I think you want organizational buy-in, as well as, even down to our pharmacy. We want to make sure that we have a multidisciplinary team of experts, which we do at Kaiser Permanente. So we leverage all the folks internally in order to make a consensus-driven decision.
So Rebecca, I'd have a question to follow up on that, because I know in our organization, we operate a lot by consensus, but it also sometimes tends to create a clogging mechanism to moving things from where we are to where we want to be. How have you approached kind of cutting through some of that organizational resistance and change resistance to get to an effective solution?
That's a great question. There are a lot of different voices, of course, a lot of different perspectives. We value that, of course. And I think leading through influence is important, but also coming down to the data, making sure everyone understands the data and the opportunity, and grounding in fact is really important. And equally on that, we typically like pilots. I say that because we want to make sure it works, to make sure that we want to scale. So we, at times, might enter into a pilot in a market and look to see what that opportunity yields, and then look at scalability. That tends to be a softer approach that we might take. But again, like from just our mission of being value-based care, I think it comes a little bit easier in the sense that making sure folks are in alignment and working with our matrix partners. And we do have a good working relationship across all of our matrix partners. And again, like grounding in fact and impactability from the financial perspective and opportunity is kind of where we always land on, right? So I think that that's really important, to ground in what the issue is, and then looking at, the impact, and also bumping up against too, do you have another internal program that might be better for a member than bringing on a vendor? And also always looking at like what we do really well, and then looking at what could augment and be basically an extension of our care team equally goes the extra mile.
Ifrod, at times you've been pulled into healthcare economics discussions, right? So let's say I'm a vendor, I've had the first conversation with the CMO, they're interested. Usually in the second meeting or third, they're going to bring in someone with an analytics background, like walk me through from very early stage pilots to mature scaling. What have you seen in kind of the range of things that have been asked for you guys to analyze?
Yeah, so interestingly, I think vendors immediately gain more credibility if they walk into the room willing to put their money on the line and take on financial risk for outcomes. I often find the more ready to go or ready you are on that, the more you as a vendor are actually given the leeway to determine the methodology, right? So the more financial risk you're willing to take, I feel like there's a little bit more room for the vendor to determine, like, here's the way we want to design the study, like, here's the way we want to track the outcomes. There's a very, very wide range of methods that we've used in the past to determine efficacy. It really depends. So much of it comes down to the size of the population that's impacted. It's as practical as that. Like we typically find that an intervention that has a very small number of people impacted, you want to employ very different methodologies versus a larger size. The timeline is also important. We can talk about that more if and when we get there. How much time do you allow before you actually start an analysis on outcomes? What are the financial outcomes that you're expecting versus the non-financial outcomes you're expecting? Some of that is also part of the consideration.
So let's talk about financial outcomes. They're not too many, right? There's 3 or 4 different domains, right? So a lot of folks are either looking to keep people healthier and out of the hospital, so to in some level of Part A affordability, or they're impacting unit cost of something. So they're taking maybe a less expensive medication, site of service, or some other entity. And then perhaps if they're impacting quality, and some plans have different mechanisms that quality is impacting revenue, right? So, Mike, I turn it back to you. If every state is different when it comes to the Medicaid plans, how do you think of something that has a mixed value between experience, affordability, quality? How do you think about them before they come in that first initial contract?
That's a good question. And one of the challenges we have in Maryland, especially with our health plan there, is we have a very unique hospital reimbursement system. So it kind of adds a layer on top of that that leads us to try to figure out, we can't control unit costs as those are set at a state level regulator, but we can control utilization. And so when we're talking to vendors and partners, that's one of our first questions is, do you understand our model? And if they say, yes, we understand, and they can repeat it back to us, then we're like, okay, great. We can have a good conversation now. Because the minute they start to say, well, we can control your hospital cost, we chuckle and then have to have the 10-minute conversation to walk them through why that may not be the case. So I think all of those are factors. I would all add in, Reza, as well, the admin cost structure, because there are some of these solutions that enable us to change our admin model and say we don't need people doing the same type of work internally that we may have if we can leverage an external partner. So when we're looking at that return on investment, that impact for us financially, that's part of it. The utilization is always a driver. Can we avoid the acute activity? Can we avoid the thing that's very expensive? When we look at, can we get someone who's taking a medication and we're paying for the medication to stay on it, use it, and drive it? All those factors kind of come into play. Are we getting an individual that we're targeting because of various health needs or complexities to take their health more seriously in a more focused manner, to be more aware? Something I've been really focused on saying lately is that we can't expect amazing things to come out of 15 minutes with a doctor every 3 months. That's not going to cause somebody's health to change. And so these mechanisms through digital tools, through other mechanisms, through partnerships, that's a way we can really have an impact because they will have many more touches with a member and their needs than we'll ever get from the standard traditional provider world. So as we're looking at it, it's really saying unit costs may not be as drivable through this, but utilization probably is, activity probably is, and really driving the right behaviors in the right way, keeping people out of the acute side. Because when we look at primary care, if we spend money in primary care and we don't spend it in the hospital side, that's probably a good thing. And we're okay there. So we may see that cost go up. We may see medication costs go up. But if we see the acute events, we see the serious events go down, then it's a win. But calculating all that, getting that all clear and trying to do that in a timely fashion is a complex conversation. Just the factors in play, the number of partners we're using, the picture we're trying to bring together, just getting the data clear, and because of claims run out and all those things, getting it clear in a timely fashion. It's a complex knot for us to manage.
Yeah. So let's go to Sebastian. You've been in this space, right? You guys do high touch care to drive med adherence, but med adherence means different things to different people, right? There's the affordability, there's the quality, there's long-term benefit for patients in their kind of clinical state, right? So walk me through the last couple of years as you've been talking to risk-bearing entities. How do you discuss what you do, and how do you measure it?
Right. So the premise of what we do is that people have trouble taking their medications as prescribed, and we help them to take them as prescribed through a near daily interaction. And it's all on video, and they're video recordings. So very short. You can think of it as Snapchat for medication taking in a grossly oversimplified way. But the hypothesis is pretty clear that the medications and the chronic conditions are excellent. So if they are taken and taken correctly, then the person's not going to be as sick as they might be if they didn't take their medication, right? And so it's pretty straightforward, but a few things make it complicated, as Mike was pointing out, to get to, well, what's the actual value here? The first thing is what you just said, which is, if I say to you, we help people take their medication correctly, and you're in the health plan world, the first thing you think are medication adherence metrics, quality metrics, which are all about refill. And refill is really, really important, because if you don't have medication, you're not gonna take it. So that's important, but that's not what we're really after. We're after helping a person succeed with their medication, understand what it is, understand how to inhale it, inject it, take it with meals at the right times, and then actually do that. So there is confusion. Then there's complexity of, well, what does it mean? And this is getting to your question. How do you measure it? Well, you can measure it in a few ways. And I think what we learned over the last few years is how health plans want to see it. So if our goal, if it mattered a lot that it was a certain percentage of medication taken, like they've taken 80% of their medication, if that mattered, it'd be more of a quality argument, like a metric, but it's not. It's really control the chronic condition, because what we're trying to do is make sure that what was prescribed by the physician, that regimen sticks, and that it's right, and that it's implemented. So that's really a utilization argument, right? That people should stay out of the emergency room and the hospital if they're taking their medication. Where it gets complicated is, well, let's just say what we've recently seen is it's about a 20% reduction. It really does matter who, though. Is it high utilizing diabetic? Is it somebody with hypertension? Is it comorbidities? Who really matters? Because the health plan will ask 20% reduction of what, right? If it's a low utilizing member, then this may be an inappropriate intervention.
But let's think about layering, right? So let's say you have a diabetes program that's job it is to engage patients and tell them healthy diet or prescribe them medications, right? And then you have this other entity that makes sure the difference between prescribed and actually taken, is there's a delta there, right? And ultimately they get better diabetes control. So, Mike or Rebecca, how do you think about if there are two different solutions that are touching our diabetic patients? Sometimes there's three, right? How do you think about attribution? How do you think about ROI? How do you give credit partially to the person who initiated the CHF, COPD, asthma program versus the people who made sure it actually worked?
Rebecca, would you like to go first?
Yes, Chair, I'll take one shot at it. So that's a hard question, and we struggle with that, right? Because it is hard to, when there's too many interventions, for the member to actually look at what's working, right? And to apply the outcomes back to the intervention. One of the things is too, you want to make sure that the member's not being touched too many times, because that could be confusing too, right? And that can lead to a lack of adherence, right? You know, you might have your own internal diabetes care management program. What I view vendors are complementary. It's not and or at times, it's complementary. And sometimes within this space, we're looking at the coaching component and the educational component, and it may not be long term, right? And so some of these things you have to look at the short, intermediary versus the long term. But I think the key is understanding the delineation and delegation of duties, because you do have to understand, Mike hit it on the head when he said the admin costs. What are you paying a vendor for versus, you know, your internal care management, case management team? Because there can be duplicate payments, right? And equally providers, right? Like when you have providers in, you know, an upside savings or some sort of value-based payment arrangement, they equally, right, could be trying to manage that member. So looking at like where the need is and being clear on the member, and actually where the engagement is. You may have a member who actually is very digital savvy and wants to try a tool, but your care management or case management cannot get that individual on the phone or to comply. So you really have to understand the engagement series too within that member and what's going to work. Equally, I think it's important that the vendor be able to have, and I think Steen does a great job at this, escalation back to care management, that does the reporting. And so you can bump it up against your own internal metrics too, because you do need to be aware of potential duplicate payments or overlap, and you actually want to make sure the vendor is successful within the contract and the context. But that is a really tricky question, trying to attribute back to an intervention when there could be multiple things going on too.
Yeah, I would agree with everything Rebecca said. And I think the other challenge of this is that to get a member's attention and to capture it and keep it, you have to have multiple tools moving at the same time. And how you do that orchestration, because this member may get caught by this one, but this member may avoid it or not be interested, but they may get caught by something else. And so you're constantly trying to figure out where the connection points are, where the engagement points are. And as we look at medication adherence, as we look at, primary care, care management, all those things, we know that just one solution isn't going to work, because we can't figure out until well after the fact what member responds to what thing. So with these multiple tools in the market, we've almost got to figure out how to start to look at it collectively. And are we seeing a collective impact in the set of structures we have focused on a chronic condition or a population of people, and then try to balance that out a bit. And then over time, see if one of the vendors we don't think is performing as well, looking at other metrics outside of just pure return. But it's a complex thing, because we're dealing with people who are complex and messy, and sometimes aren't the easiest things to get to discrete data points.
And Reza, I would add on just quickly, I think Mike's spot on, but additionally, I think it could be different between adult and pediatric populations. So, digital savviness, and, some plans or some vendors don't, you maybe have like as a robust pediatric, program, or some vendors will not, they don't offer in the ped space, right? So looking at that engagement and equally self-service in a digital tech savvy world, equally where the member lives, urban, rural, where the hours that the member might be working, for instance, right? Maybe like a tool like what Steen has, where the member at their own self-service and discretion can actually, log on within hours that suits their time, where it might be outside of, normal business operating hours for a health plan. Specifically around pediatrics too, we know kids are really tech savvy, and we know, for instance, a lot of our DSIP members are tech savvy too, right? So it just really, I think you have to isolate and understand your population too. And I think that a strong vendor, and Sebastian, Riz, I don't want to hijack your presentation, but I think that a company like Steen probably has it down after a long tenure in this space, like on adoption and engagement within age cohorts.
Yeah, I would say, listening to both of you, you're always learning, right? So in terms of having it down, we've learned a lot and have a lot of data. So we've learned what we've learned, but there's a lot more to come. What I can see is that from both of your perspectives, you're thinking it for large organizations, very, CareFirst, Kaiser, Prominence Health, very large organizations with a lot of moving parts and a lot of different programs. So there's probably a high level thinking of, if we get a certain number of people onto digital engagement, then they are going to be in a track where they don't need to go to the emergency room for their care or for advice. They're generally speaking going to be easier to interact with because it's hard to get people on the phone. So digital engagement at a high level's got to be, in the longer run, an effective channel. It's just that it's been partitioned into so many different areas, like whether it's diabetes management for this, or kids for that, or aging in place, et cetera. So I think from the vendor side, though, while you may have, Mike and Rebecca, that high level strategy, from the vendor side, you have to be very, very targeted and understand who is the best fit for your program from the member point of view. And you've got to go find that member, because on the one hand, of course, all vendors will want to increase their revenues, right? But the more people you take on into your program that have no chance at a return in any way, the more you dilute your return on investment. So I think to answer the original question, obviously, like it was posed to Rebecca and Mike, but it seems from my seat, it's being able to measure has a lot to do with being able to first do risk stratification and pick the groups that have ROI for your program, and where that if you did certain things, that it would probably lead to a certain effect, which is positive. And if you can analyze at the cohort level, the more data you get, the more you'll validate, invalidate, and be able to fine tune.
So that makes sense. So let's assume we've picked the right population, we've picked the right intervention, we've gotten a decent amount of engagement. Ifrod, I'm going to turn to you. Something as simple as reducing, unnecessary hospitalizations. It seems like there's a couple different ways about going at this. One is kind of counting widgets, right? Like preventive episodes, and the other is kind of large scale admits per thousand, et cetera, right? Walk me through some of the methodology in each of these domains, and what do you expect from different size vendors and organizations?
Yeah, so I'll talk maybe primarily about a statistical methodology that really gets at an efficacy analysis. Just a warning, like this gets a little nerdy, right? But I think folks on this webinar might appreciate it. It's called a difference in difference analysis, right? So if you have an intervention that you're applying on a particular subset of the population based on the stratification that Sebastian was talking about, and then you can identify a like cohort of a population who's not getting that intervention. A difference in difference analysis basically tracks the performance of each of those cohorts over time. You can think about them as a treatment cohort and a control cohort, right? And how is the performance improvement over time different between the treatment cohort and the control cohort? So back to your example of avoidable hospitalizations. In my experience, that has been the truest and most unbiased form of informing a leader whether the avoidable hospitalization effect is truly significant in the intervention population. One other kind of example I'll play, I think one of the strongest studies and maybe somewhat relatable study that I've read with kind of measuring digital health ROI. It was in a cardiology journal about remote patient monitoring in CHF patients, especially CHF patients who may be getting multiple programmatic interventions, right? So that's come up in conversation, right? Like sometimes, depending on disease cohort, you may be throwing a lot of different types of interventions at the population. But assuming that there's one specific intervention around remote patient monitoring that you're applying to this population, you can actually track that pretty specifically when it comes to, say, CHF related hospitalizations. One thing I learned from this study as a non-clinician is that weight tracking is super important for CHF patients. Even if there's like a 5-pound change in weight, you got to titrate the medication to make sure it's adjusted properly. And if you don't adjust it, then there's a possibility of CHF exacerbation. So there's a very clear line that you can draw there between the intervention population and CHF related hospitalizations. So you can actually start to get like early indicators of your performance even before you complete a full 12-month period and have your teams perform a more thorough like difference in difference statistical analysis.
Let's talk a little bit about duration of impact. Sebastian, I remember looking at your data about a year ago, and there was, at least in some of the analysis that we did, people who got an intervention 2 years ago had long-term sustained benefit, which is typically unheard of, right? Like in a difference of differences, you weren't playing whack-a-mole with data, but you were actually changing the way they actually take their daily medications. And this had profound impact in 1 year, 2 years down the road, and reduction in ED and inpatient and so on. So walk me through like the duration of impact, like from theoretical to what you were able to see, and how do you connect the dots for the risk-bearing entities?
So there is a lot of complexity, and I'll start by so at about a year ago, I actually brought an analysis to Mike on hospitalization reduction, and we had measured the reduction in hospitalization based on days in hospital total. Like we'd summed up the grand total of days, and Mike was like, "That's really impressive, Sebastian. However, you should know that during the same time period, we've been running a program to make sure that people are able to leave the hospital when they're really ready and get them into other forms of more efficient care. So the length of stay might not really be your target," right? So we were back to the drawing board at some point to really try to nail it down based on number of visits, because then Mike also explained that in Maryland, unit cost changes during the year as the hospitals make up their assigned revenue. So there's always some complexity. I think in terms of long-term benefit, this difference of differences approach works if you're measuring a long pre against a long post. So you need to be able to have the data to do that. You need to be able to say, and then statistically, making it statistically significant, you need a large group that's engaged. And Ifrod can confirm or put this in better terms, but you need the cohorts the cohort you're comparing to be also larger and very closely risk matched. So I would say we do know that 12 months out from engagement, we've got a very clear reduction in utilization. I think it's gonna take more to know that it lasts a really long time, especially in Medicaid, where life can intervene, anything can happen. So it's hard for us to make claims for the long term, beyond 12 months. But the longer we can keep analyzing data, keep engaging, then hopefully we'll get to like a sizable analysis.
So I'll go back to Mike. Let's say you have something, whether it's seen or something else that works, and they have affordability outcomes at a year out, etc. How do you think about churn, right? Like we've provided value to the patients, but these patients may not be ours next year. Like, do you guys have a standard analysis that you think about this, or what's your philosophical framework around driving value, which is the right thing to do, but in the long run, this patient may not be ours?
So that's a complicated question for us. So we are a not-for-profit health plan, and part of our mission is also to serve the community and to make healthcare affordable and accessible and impactful for people's lives. So when we look at that conversation, we can't just stop at the value won't accrue to us. It's, are we doing the right thing for the individual? Are we starting from that perspective of what's the right thing for the member, for the person we're trying to help, for the person who's asking us for help? And we've got to start there. And so it may be great. They may be with us for 9 months and we can do a great service for them and the impact. And then they may move on and, hopefully they have a very positive perspective of CareFirst, given our large position in the market. And when they're looking for healthcare from other sources, or they have a different type of arrangement where they're no longer on Medicaid and they've moved to a commercial or the individual market or something else, that they choose us because of that as well. I think, and the prep Rebecca was talking about, it's just the nature of people moving between products. And I thought that was an excellent observation on her part of just how that plays out. And we've got to think not just from the product we have them in today, but how their life evolves and changes. And we want to make sure that we have not only an offering and set of offerings for them to continue to stay with us on the insurance side, but we want to have a positive impact on their health and an impact on the health of the region. And so trying to balance all those things out leads us to probably not worrying about that as much as we might if we were different types of organizations, but looking and saying, what's the right thing to do? Let's start there. Let's try to help people be healthier. That should lead to lower cost and better outcomes. And then that should lead to, longitudinally at just a better impact in the community and hopefully a good positive perception of our organization and the things we're trying to do.
And Reza, I would absolutely agree with Mike. I mean, our organizations are similar, nonprofit. We want to make sure that the health of, the whole community, right, is reflected. And I think that there are what I would call some soft ROI. We know our financial folks love the hard and fast data. They love attributing the savings to a program. But one of the things that we talk about internally is social isolation. And we do, if you think about urban and rural and communities and age populations, some of these digital tools, you may not see an immediate impact, or you may not be able to say, Rebecca's not going to the ED because she's able to talk in a digital space, right? It's serving a purpose. She's being validated, right? Versus going to the ED. I think that some of these tools can potentially take the strain off the system too, right? If you think about 911, EMS, our hospital providers, community providers. And so there's a soft ROI that goes into enhancing a member's life. And that's hard to attribute. I mean, IFRA might have a different way to configure some of these, savings, but I think that those are the personal aspects, right? That from a mission organization, we're very concerned with. Of course, we need to see the financial impact too, but some of these things are hard to quantify. And so those soft things, whether it be in caps, or you might see grievance and appeals go down, or just something different, right, to quantify, to look at that, measuring an individual quality of life is super important too, to be looking at that cross connectivity and that verbal, right? Like feedback about what you're enhancing with someone's life. That's why I love the Seeing Health videos, right? Because you actually are seeing the member being honest. And Mike, some of these folks might be your members, I don't know, about being honest, about what this tool has done to empower them, coach them in the comfort of their own home, on their own time. And I think we live in a world of choice. Choice is so important. And I think we have to be choice centric in how the member wants to engage as well.
Yeah, I couldn't agree more. I help with a variety of digital health solutions around when they pitch or when they talk about the value that they're creating, be comprehensive, right? You talk about the numbers, you talk about experience, you talk about, HEDIS and RAF and other aspects depending on what the audience is. And then when you go to contract, you might have one or two metrics in your service level agreement, which is a smaller subset of the broader value that you're creating. But I guess one of the questions I have is, let's say you have now a program that's worked. The pilot has been successful. They've reduced unnecessary hospitalizations. Now you're looking for them to scale. And Ifrod had mentioned getting some skin in the game. So what's a range of the percent of the value created that you'll be willing to share with a vendor? So let's say it's measurable, they've done differences, or someone's got MLR, value, et cetera, right? Is it 10%? Is it 15%? What percentage of the value created, assuming you could attribute it primarily to one vendor, would you be willing to share? We're not going to hold you to this, but just as a guideline to our listeners. We'll start with Mike.
Sounds good. I think it's not an easy answer because we're really looking at the shared savings impact. We're looking at the baseline of the population or the set of people we're aiming for, and then saying, what have we seen change in the trend and the expectation? And so we're looking at that often at a PMPM level or as a MBR perspective, depending on the product and the structure. And then we're very open if we see considerable savings to split that in a way that makes sense economically for the partner as well as for us. But I wouldn't say it's 10%. It's probably more than that because economically the partner, the vendor has to be viable too. And we need them to be able to have some skin in the game, feel that this is worth their time, feel that they can make a viable business. Because while we as the health plan want to capture every possible thing we want to, we also have to make sure that our partners are viable long term and that they have a good financial position that they can operate from, grow, develop, bring in new customers, help us enhance and develop what they're doing over time, because none of this stuff stays static either. The populations evolve, the behaviors evolve, we get resistance in the populations to certain tools and things. So we know all of this has to continue to change, and change costs money. And so we don't want to put ourselves in a position where we're, so tight with a partner or a vendor that they just can't keep up with what's going on in the market either.
Ifrod, I go back to you around, the metrics and things that you want to see when a program's looking to scale. What are other domains that you're thinking about, either in your current seat or when you worked for that large conglomerate previously, around helping articulate the value of a solution that's a little bit more mature?
Yeah, so I think first thing I'd say is do not underestimate the power of leading indicators. I think Rebecca alluded to that a little bit, right? Like the softer ROIs, also engagement metrics and things like that. So I think those metrics become very, very important when we're going from like a pilot mode to a more scaled up version. A good example, maybe a very simplistic example, would be like I've seen in an ER diversion type of initiative, there's been a lot of messaging sent out to the patients about ER alternatives, whether it's urgent care availability or nurse line or a digital health type solution like telemedicine. One of the leading indicators I've seen used is, how many people open the email, right? You can actually, depending on what system you're using, you can actually track that. So that's a perfect leading indicator for, is there even any engagement on this program, even though you have no idea yet about the ultimate outcome. So I think the leading indicators are very important for the pilot. I think the other thing I'd say is I have rarely, I want to say never, but I'll say rarely ever seen a evaluation either during pilot or in a scaled up version that has a very binary answer, that yes, it does work, or no, it doesn't work. The answer is almost always, we think it can work better if we did XYZ instead of ABC. One evaluation comes to mind that I was personally involved in. There was a telemedicine behavioral health program which showed very little ROI. But when you dig into it, it turns out that the low ROI, or in some cases the negative ROI, was really on the higher prevalence conditions like depression and anxiety. But when you really dig into some specific areas like PTSD or people recovering from substance use, you actually saw different outcomes, right? So that's an example of, making sure that when you're scaling from pilot to, a larger population, let's make sure that you're looking at the nuances around the program performance and not necessarily looking for like a yes versus no answer.
Yeah, I'll go back to Sebastian with this, stratifying by subgroups and cohorts, right? So we talked about, if you have a high utilizer population, it's easier if they had previous utilization to see that, it had an impact that their utilization went down, versus if you had a low utilizer population, perhaps, you saw improvements in quality or engagement or experience or other things. What's been the appetite for having the same solution stratify results by different cohorts?
Yeah, so it's easiest to start with a higher utilization because you have a clear reduction if you actually achieve it. Whereas if you didn't have it before, it's a prevention argument. But I think that's ultimately the customer's choice, like the health plan's choosing which members to apply the solution to. Now, if you have a really large engaged group, you should see a prevention argument come through as well. Like in the control group, there were more hospitalizations than in your group, but you may not see that you had a significant, by yourself, without that control group, you might not see significant reduction because there was nothing beforehand. Medicaid's really, if you look at health outcomes, which is where we started, like A1C, blood pressure, you have similar problems where you have no values on file, especially in Medicaid. So there's no pre-program A1C. And that's a really hard situation too, because are you going to ever prove that you reduced their value? And the answer is maybe not. But if your group, again, tends to have over time, lowering A1C, then that's so Rebecca, you mentioned like the videos are really great. And so, yeah, we'll show member videos to Mike and other health plan customers, but you also need, it feels anecdotal because we have a lot of members who just don't say anything on video, right? They're quite shy and they use the chat. So we're not going to show those because they're quite monotonous, right? A couple minutes of silence and in a dark room. So data is really, really, really important here. Like having mastery of your data, which is it's not automatic. It doesn't happen in a year or two. It's years of looking at your data against claims data, figuring out those email opens and those little indicators. And it's a lot of little things that you have to come to understand and interpret. I think, Mike, you were going to say something before I start. Sorry, Rebecca, go ahead.
No, I was going to say, I love what you just said. And equally, I was thinking about other complementary digital solutions. So when I think about the wonderful work you all do within condition specific, that work for those populations, I think about one thing that I love is a compendium of services and communication. And so what first comes to mind is the virtual health partner, nutrition, dietary assessment. And so someone might be engaged with a company like that who's getting coaching and who has access to cooking and, yoga and just a lot of different activities to be helping that condition and then equally enrolled in your program. So having that awareness from, being transparent as the payer about who's touching the member equally is important so that everyone's on the same page and you can actually support each, vendors being successful. I'm a huge champion of that personally.
Thank you, Rebecca. I was going to emphasize something that Ifrod had said, learning. So many of these solutions don't work quite the way we all hope right out of the box. And we build these beautiful ROI models and these beautiful understandings of everything, and then they don't work or they don't quite get to where we want to. And I think diving into the data, learning about what's going on, understanding the details and the nuances and seeing what is different than what you expected. I can't emphasize that enough. It's the curiosity to see what are you learning from the process, because even if it's not working, you're going to learn something. You're going to learn what might work and know where to aim and work with the partner to get there, because they're there, they're engaged, they're started, they're involved. And that's just we too often want to say, well, it doesn't look like it's working, so we're just going to cut the whole thing. And that's a mistake that can be made because you miss the window to get smarter about something you may not know.
If I think about some of the common themes that were discussed today, right? So somebody has a solution, they come in, they get it going. You need the early indicators, get some engagement data, and then hopefully you have some clinical data, right? You improve some blood pressure, cholesterol, diabetes, what it may be. And then down the road, you're going to hopefully have some impact on utilization and other aspects of savings, or depending on what the plan structure is, things that impact their revenue. And then ultimately, if you get to a level of maturity where you have some sort of value-based contract where you're getting a piece of the action you're creating for the other side. And in each of these sub lanes, there's a lot of complexity and a lot of one-off things that need to be done and measured, and having a partner that's willing to partner with you when things are not going well, and so on. So I guess I'll go around the clock one last time to see any advice you would have to solutions that are looking to pitch something or scale something in this space in terms of how they think about and talk about their ROI. Rebecca, you want to go first?
Yeah, I think we love just being an evidence-based organization. We love peer-reviewed, data-driven, research articles that really provides, some comfort, to our internal team, along with, demonstrable experience with other large payers within this space is really important. So for us, experience is important because we really want to make sure that, and again, we know that folks have to start somewhere, but for us, that demonstrable experience with, research-driven outcomes is important to us. But equally, a flexible partner, just what you just talked about, right, is willing, able to, a nimble partner is really important because we hope that partnerships last and we want them to evolve. So learning, like what Mike talked about, learning and growing together, and, members' needs keeps changing, right? So we want some fluidity, around, especially, as in some of our markets of natural disasters, folks get displaced. That could be a change to the roster, right? The threshold of membership engaged could go down. So really just, we look at some of those softer things too, not just the hard and fast metrics. And so we're always looking for the right partner. But again, we have our own due diligence to come up with a problem issue statement because we want to make sure we set the vendor up for success. So internally, it's really important for payers, if you're looking for a vendor, from my perspective, to understand exactly the issue you're trying to solve, because there's a lot of vendors in this space and a lot have wonderful outcomes, but knowing exactly the cohort to map, because that's going to be equally very important. And I love having a vendor who actually will do their own data analysis because they're trying to set themselves up for success too. So having that degree of confidence between both parties, I think, is critical and foremost.
Yeah, I'll
Mike?
build off.
Yeah.
Yeah, I'll build off what Rebecca was saying. I think the evidence piece is very important. And I think the other part is, while you're talking about the evidence, the digital part isn't the story. It's the how's the person engaged, how's this person changing behavior, how's the person understanding their condition or their needs more. It's great and wonderful to say, hey, we have an app. And I was quoted at a panel a few weeks ago saying, when a vendor came to me with this, I said, thank God, not another app. So it's just this, the app isn't the starting point. The app is the mechanism, it's the tool. And the concept, the idea, the process, the methodology, those things are the important part. The app just gets you to scale. But we really want to understand is, how are you doing this? How are you impacting the individual? How are you getting them to engage? How are you keeping them engaged? And how are you having a real impact on their health and their life? That's the story. So, don't worry about the demos. Talk to us. Tell us how you're doing this. Tell us why. Tell us what's important to you. Tell us what you're focused on and what you're learning and how you're evolving and changing as the population does. And I think that's a much more effective way to tell your story to a payer than just to say, hey, let us show you your demo in 2 minutes after you start the presentation.
Ifrod?
I might just leave with a very technical tip. I think I was called on as the token technical guy here. So one thing that I see very underutilized in the measurement sphere is, for Medicare, you actually have a very convenient control group, and that's fee-for-service Medicare members. You can actually buy or sometimes even freely tap into a lot of fee-for-service Medicare data that the government makes available. And that population tends to be a population that's untouched by a lot of interventions as opposed to Medicare Advantage lives. So if you're a health plan managing MA lives or a service provider serving MA lives, you can lean on fee-for-service Medicare data as your counterexample of the MA experience. Not only that, but you can even specifically look at non-duals, dual eligible, ESRD members, disabled members. So I've found that it's a very, very convenient kind of cohort to look at as the counter argument or the counter example to what you're serving as the vendor.
Sebastian?
Well, I like actually what Mike just said about it's not the app, because it's interesting in the whole world of digital health. there's very, very few actual what are called digital therapeutics where the effect of the software is driving anything, right? So that there are a few, they're not very persuasive, right? That the software by itself is creating some kind of like health improvement. So really it's a channel, it's a communication channel in most cases, whether it's to get blood pressure readings or to do an assessment that you would then act on with a person. So I think the age of the fact that, digital health would be some form of magic has dissipated out, now that we've got 12 years of digital health. And the real question is, well, what exactly are you doing? There's still a lot to learn, even though we have a hypothesis that is, well, we're helping people take their medication, and they typically don't take their medication as often, but you're still learning. So perhaps it really struck me in an earlier conversation today that what we do is closer to a home health visit than it is to anything else. And perhaps people are staying out of the emergency room because they have somebody to talk to now conveniently. So there's a lot of learning to do, but it's the hypothesis behind what you're doing has to be really crystal clear. So, and then there are anomalies, like Rebecca was talking to us earlier about wildfires in Oregon and California, like what impact that has, what an anomaly in the data. Can you see that? It's a lot of complexity too to manage. I just saw that there are some questions, Reza, if you want to maybe grab one of them.
Yeah, I was going to make one quick comment and then see how much time we have for the questions. I guess my last comment was, having worked for a national provider, my advice would be to have a nuanced view of what is their current state and what is incremental. So what might be incremental in one market may not be incremental in another market. So let's say you mentioned Medicare Advantage. If in some market they've already reduced their admits per thousand in the senior population to 150, it's a very different starting point when it's Medicare fee for service and their admits per thousand are 300, right? Or if you're talking to a state-specific plan that has pay for performance on specific quality metrics versus a different state that doesn't have, they care about quality, but there's not a large financial reward for improving this metric for 500 patients or 1,000 patients, et cetera, right? So having a nuanced view of not only what you can do for your patients, but how does it align to the business model of that local piece of that national entity, it is quite important. So I guess in the last minute or so, there were some questions around the CHF, and we'll try to answer those offline. I think there was a couple of technical questions around CHF measurement and so on. Anything else, guys, as we wrap up?
Great conversation. Thank you.
That was really great to be on with you guys. That was a great perspective that I normally don't get. Thank you.
Thank you, everyone.